Can we will start now. Good afternoon, everyone. Welcome to weekly webinar organized by College of Physicians Malaysia. We are now in the week 4 of Nephrology Month, and topic for today is acute kidney injury and dialysis. We are fortunate to welcome our speaker, Dr. Tan Chi Shang, our consultant nephrology from Bagan Specialist Center, and our chairperson today is Dr. Zaiha Harun, who is a consultant nephrologist and head of nephrology department, Hospital Sultana Nur Zahira, Kuala Terengganu. Datuk Zaiha is graduated from University of Adelaide, South Australia in 1994, and she completed her Master in Internal Medicine in 2003 at University of Science Malaysia, USM. She completed her fellowship training in nephrology under Ministry of Health Malaysia in 2008. Since then, she is a consultant physician and nephrologist of Hospital Sultana Nur Zahira, Kuala Terengganu. She also is a state nephrologist of Terengganu since 2014. She is actively involved in publishing and writing research papers. Without further ado, let's welcome Dr. Zaiha.
Thank you very much, Dr. Priscilla, for your kind introduction. So let me introduce to you all, Dr. Tan. And by the way, welcome to all of you to the webinar nephrology. This will be the last weekend of nephrology. With the topic today is acute kidney injury and dialysis. And to deliver this talk will be our speaker, Dr. Tan Shi Xian. The Tan is currently working at the Bagan Specialist Center, Butterworth, Penang. Before that, he was with us in Ministry of Health, and Dr. Tan received his undergraduate studies from Malacca Medical Center, Medical College, year 2008. And he continued doing his MRCP, which was completed in March 2012. And Dr. Tan underwent nephrology subspecialty training, Ministry of Health in 2019. And he's working, he has very vast working experience, and most of his time was in Kedah, and from the year 2008 as a house officer, medical officer, and a physician in Hospital Sultana Abdul Halim until 2015. Before then, he was then stationed as a consultant nephrologist back in Hospital Sultana Bahia before he was transferred back to Hospital Sultan Abdul Halim as a consultant nephrologist there. Dr. Tan was the key player who established a nephrology service in Hospital Sultan Abdul Halim Jitra Kedah. And looking at his CVs here, he was very keen, very interested in terms of setting up critical care services in the Hospital Sultan Abdul Halim, setting up PD unit. I remember that he was the one that really pushing up the PD patients in Kedah. And he also has interest in intervention nephrology. And Tan also very actively involved in teaching, research, and he has published a lot of research papers and poster and oral presentation in the areas of acute kidney injury. And I think he's the right person to talk about AKI today. And he has published locally and international journal such as Kidney International. So without further ado, today we let the ball rolling. Tan, the floor is yours.
Okay. Let me share my slide. Okay. Can you all see the slide?
Yes,
So
yes.
Thank you, Dr. Zaiha, for the kind introduction. Thank you, the College of Physicians, for the invitation. Today, I'm going to share with you guys on acute kidney injury and also dialysis. So this is the outline of my talk today. I'm going to tell you on the epidemiology on AKI, and then followed by how we define AKI, and why is AKI so important, what is the impact of AKI in the short term and long term, and then the four that I highlighted today is our main discussion. What is the trajectory of AKI? And then when is the best time to initiate dialysis? Whether should we start early or late? And then I would like to introduce you on the Fukushima stress test. And then lastly, but not least, I would like to share with you on how we choose the mode of dialysis, whether it's hemodialysis or CRRT. The picture here is the hospital that I just recently joined. So what is the epidemiology of AKI? In AKI, the percentage is around 2% in all the inpatient admission. And most of the admission to ICU, as high as 40%, are AKI. And we check the prevalence, it would be more than 60% in ICU admission. And among all, 6 to 13% of them would need dialysis support at some point of time. This is a picture of my current hospital. This is my team running the AKI service in the ICU. So what's the incidence of AKI in the critical ill in Asia? Look at the blue column. So we have as high as 30 to 50% of AKI incident in Asia. And when you look at the red column, the mortality of AKI patient is as high as 50 to 70%. How about in Malaysia? According to Dr. Gong, who published the paper, so we have 7% of AKI admission. And among all, 8% of them would need dialysis support, and there would be 8% of them would die during the admission. How about in ICU in our country? This is similar to the international epidemiology as well. As high as 60% of them would experience AKI. So how do we define AKI? According to KDIGO 2012, if we have a serum creatinine increasing of more than 26.5 micromole over the past 2 days, it is considered AKI. But if you don't have, then you check whether the creatinine is increased by 1.5 times of the baseline, presuming it occurred prior 7 days. If yes, then it is AKI. If the serum creatinine doesn't fulfill the criteria, but the patient has a reduced in urine output of less than 0.5 ml per kg per hour for 6 hours, it is AKI. And KDIGO 2012 also stage the AKI into stage 1, 2, and 3. So, as I mentioned earlier, if you define AKI, if you develop AKI less than 48 hours, and then the AKI will continue from day 2 to day 7. And then we know when we define chronic kidney disease, we say it is a persistent abnormal kidney function after 3 months, which is day 90. So there's a big gap from day 7 to day 90. Nowadays, we call this gap into acute kidney disease, AKD. And when patient develop AKI, what is the renal recovery? According to ADQI, we classify the recovery of AKI into early recovery or delayed recovery. If early recovery means they recovered within 48 hours, and the delayed recovery means it recovered from 48 hours to 7 days. But if the AKI does not recover fully, it will develop into AKD. And if patient have AKD, I mean the long-term effect will be worse compared to those recover early. And why is AKI so important? AKI affect distant organ. All our organs will crosstalk to each other. When develop AKI, you will have a lot of uremic toxin, you will have acid-base disturbance, electrolyte disturbance, inflammation, oxidative stress, and all the neurohormonal dysfunction. And when it affect the brain, you will have uremic encephalopathy. In the long run, you will have dementia, stroke. If you go to the heart, you could get CCF, you could get ischemic heart disease, could cause acute lung injury, pulmonary edema, altered hepatic metabolism, altered gut metabolism, and as well as systemic inflammation. How does all this occur? According to Xiao et al., there will be a conventional 4 mechanism, which is first one will be acute uremic stage, second one is due to inflammation, and third one is due to the disease itself, and the fourth one is due to the treatment that given by us, which is dialysis, anticoagulant, antibiotic dosing, etc. And all this will involve cytokine, leukocyte extravasation, oxidative stress, etc. And it will cause a lot of end organ damage. When we talk on long-term outcome on AKI, if we have one episode of AKI, you will increase 15% risk of stroke in the future, and you will have increased by 50% risk of to get congestive cardiac failure or myocardial infarction. So if you get the AKI, more severe type of AKI, your serum creatinine increase more, then the mortality will be higher. And when we talk on short-term adverse outcome, you discharge from hospital from AKI, the 30 days mortality, if you have a stage 3 AKI, is as high as 40%. How about those who have AKI and discharge home? The risk of entering into dialysis, become end-stage renal failure is also higher. In 1 year time, there will be 2% increase in risk, and in 5 year time, there will be 3.9% increase in risk. And now I'm going to share with you, start from here will be more important because it will interlink with each other. What is the trajectory of AKI and kidney replacement therapy initiation? Very often, when we have a similar patient who have a urea of 30, creatinine of 300, when we consult the nephrologist, for patient A, we would say, okay, go for dialysis. Whereas for patient B, we would say, oh, this one we could wait. And for patient C, we might say, oh, this one, no need dialysis. Sometimes we don't understand why with a similar patient profile, but the decision is different. This is because of this trajectory of AKI, which I'm going to share with you. We divide it into group A to group E. In the group A, the patient has AKI. The AKI will continue to be worsened, and you will need to start the dialysis when they touch the renal replacement therapy threshold, or else it will continue to get worse. While in group B and group C patient, when they touch the threshold of dialysis, however, they are slowly worsening. So there is some time we can wait and watch, but at some point of time, they will need dialysis as well. Whereas in the group D, when we wait and watch, they might become okay, they might recover. And for group E, there's no indication for dialysis at all. So when we talk on when should we start on dialysis in AKI patient, according to ADQI, there will be a demand capacity balance. When we talk on demand, it means the disease burden, the solute loads, the volume loads. When we talk on capacity, it means the kidney function, whether it's abnormal or normal. So there will be the demand capacity balance. So when the demand capacity balance is similar, then there's no role of dialysis. Whereas when the demand increase and capacity reduce, I mean the patient has abnormal kidney function, we need to plug the gap with either medical treatment, which is diuretic, sodium bicarb, hyperkalemia medical treatment, etc., or we need to put them on dialysis support. So what's the way to enhance the prognosis of AKI? Early diagnosis of AKI is important. Awareness and education of AKI is very, very important. Do not take AKI lightly. AKI will never be okay. Some hospitals have AKI e-alerts. So when the serum creatinine increased by 26.5, then the EMR will pop up, remind the doctors. Of course, nowadays we are also talking on AKI biomarker. However, I'm not going to discuss this in today's discussion. And also AKI care bundle. And when patients have risk factor for AKI, you must always manage the risk factor. Discontinue all the nephrotoxic drug, ensure the volume status is adequate, Oliver support the hemodynamic, monitor the kidney function, urine output, avoid hyperglycemia, try to avoid radial contrast, stop the ACE emitter or ALB when there's a risk of AKI. And if they develop AKI, try to manage the fluid management, support the BP, and then control the sugar, avoid nephrotoxic drugs, and of course, optimal timing to initiate dialysis and choose the correct mode of dialysis. When they recovered from AKI, make sure we have always follow up them in the AKI clinic. What is the decision to start kidney replacement therapy? It will be a early start. What is the benefit? If you start them early, you can manage all the complications of uremia, where there will be better volume control, electrolyte and acid-based derangement can be controlled. If we are talking on septic AKI, then there's immunomodulation of clearance of inflammatory cytokine. And of course, as I showed you earlier, there will be a lot of distant organ effects, so we can mitigate them. And what is a shortcoming of AKI, early start of dialysis? The potential risk and complication of vascular access. When we put in too early, that might cause hematoma, bleeding of the catheter insertion. And sometimes we use anticoagulant as cause of bleeding. And when we put patient on dialysis, there's always a risk of iatrogenic hemodynamic instability, loss of nutrients and trace element. And when you do dialysis, the recurrence of antibiotic, the dose will need to be adjusted. And of course, if there's no need for dialysis, don't put them on because it will be unnecessary exposure to dialysis, increase the workload, resource, and use of and cost. So again, the early start of dialysis, the advantage is we can control the metabolic, potassium, acid base, and volume as well. And we potentially can reduce the mortality and length of stay in ICU. But if we start too early, there will be always a problem with mechanical problem, catheter insertion, bleeding during the catheter insertion, CRBSI, because of prolonged catheter use, and dialysis problem like hemodynamic instability. There's also some risk of delay in renal recovery, and of course, logistically wasting of manpower. How we define early start? When we say early start means there's a preemptive start of dialysis. It's always when the KD goes stage 2 or stage 3, then we started on dialysis. This is early start. The goal of early start is to prevent development of life-threatening complication of AKI. Well, when we say late start, it's not late. Basically, it's just a conventional start of dialysis, which means we wait for the life-threatening indication to appear, then only we put them on dialysis, which is the persistent hyperkalemia, potassium more than 6, severe acidosis, pH less than 7.15, bicarb less than 12, life-threatening fluid overload, persistent uremia, etc. Whether early start good or late start good, so I summarized the 4 famous trials. First is the ELAINE trial. ELAINE trial basically show that if you start them on dialysis early, they actually reduce the mortality. However, this trial, majority of the patients are surgical patients. Well, when we talk on Acute trial, the trial number 2, they clearly stated that if you start them too early on dialysis, there's always increase of infection. And delay start, some of the patients might be avoid from dialysis. Acute trial is majority are medical patients. And when trial number 3 is IDEAL trial. It's basically study on septic AKI, and it noticed there is no significant difference when we start them early or late in septic AKI. So the 4th trial will start AKI trial. It stated clearly in the early RRT, there will be no risk reduction in death. Instead of that, there might be a higher percentage of them will have RRT dependent. I mean, they will depend on dialysis longer. Nevertheless, if you start them early, there will be always a shorter ICU stay. Since all the trials are contradict with each other, sometimes we are in dilemma. Should we start early or should we start late? How are we going to decide? My opinion is I usually practice if there's a surgical case, the surgeon went in for major operation, 6 to 8 hour operation, and post-operation patient develop AKI. I always try to start them early. The number 1, we need to support the patient. Of course, number 2, we also need to support our colleague who have went into operation theater for a very prolonged time. Whereas if in medical type of patient AKI, that's usually I would try to wait until the conventional indication appear. Whereas of course in septic AKI, there's a totally different scenario. Whether we want to start them early or late, there will be a personal choice, whether you want to do immunomodulation at all, which I'm going to share with you later, is how I practice. What does the guideline say? According to KD Go, you start dialysis only when there's a life-threatening change in fluid and electrolyte acid base. And always, when we want to start patient on dialysis in AKI, always consider the broader clinical context. Do not read at the single urea creatinine. Always look at the trend of the laboratory result, and also look at the patient condition, any modifiable risk factor, which we can try to play around and avoid them from dialysis. However, in ADQI, which I have shown earlier, it basically depends on demand and capacity. When the demand more than capacity, then you need to start them on dialysis. This is the what guidelines say on dialysis initiation in AKI. Now I switch away a bit from the dialysis AKI. Now I'm going to introduce a very important drug, which is furosemide. We know furosemide is our day-to-day drugs. Furosemide is a protein bound. It will be excreted in the proximal tubule, and then it will go to the ascending limb or distal tubule and act over there. And when in AKI patient, very common, you will use furosemide. But always remember, there's a potential problem with furosemide in AKI. If you use furosemide, we might improve in urine output, and we might causing delay in the diagnostic and therapeutic process of the underlying cause of AKI. And of course, AKI can reduce the potassium, phosphate, magnesium, and metabolic alkalosis. Other issue with furosemide is when you use furosemide, there might be a limit the use of urinary sodium to differentiate hypovolemia and normal volemia. And furosemide can delay dialysis, which might increase the mortality. And high dose furosemide can cause ototoxicity. And furosemide also reduce the mucociliary transport and sputum clearance. So you might delay the recovery of pneumonia. With all this in our mind, I would like to introduce to you this furosemide stress test, which is very, very important test, which means when you give a standardized dose of IV furosemide, you wait for 2 hours, you look at the urine output. If the urine output is less than 200 mL in the 2-hour time, which means it is a furosemide non-responsive. So it predicts the progression to severe AKI is very high, the need of dialysis and death. And we always talk on AKI biomarker. If you look at this chart by the chart, you could see if you use NGAF, KIM1, KIM2, etc., the area under the curve is only around 60%, whereas furosemide stress test is as high as 80%. And it is also very cost-effective, very cheap compared to the novel biomarker. So according to a trial, if you put them on furosemide and you wait for 2 hours, if the urine output does not improve, then it is very likely the AKI would progress. This is a paper on the furosemide stress test trial. We could go to Google in internet. How we do furosemide stress test? Basically, we give furosemide IV 1 mg per kg, or a patient has exposure to furosemide before, then you give 1.5 mg per kg. And then you wait for 2 hours, you look at the urine output. If it's more than 200 mL in 2-hour time, it is called a furosemide stress test responsive. If they are responsive, then we could wait further. We can wait for the dialysis indication to appear, urea more than 35, potassium more than 6, bicarb less than 12, etc. So at this test, when you do a furosemide stress test, actually it excludes 13.6% of the patient from dialysis from the beginning. If the patient is furosemide responsive, which is as high as 13.6%, they can be avoided from dialysis. Well, if they are furosemide non-responsive, and then which means they are more severe AKI, they will need dialysis at some point of time. Only 75% of them enter into dialysis. After talking on when should we start dialysis, what is the role of IV furosemide, the last topic today will be I'm going to share with you how we choose the mode of dialysis. I exclude PD, even though I'm the strong PD supporter, because in my opinion, we shouldn't do PD in any AKI. So when we want to support dialysis in AKI, there are a few modes of dialysis. The first one will be in the green color because intermittent hemodialysis. So there are two types, HD and HDF. Well, the conventional one would be hybrid therapy, SLAC and SLAC-F. And in CRRT, we have CVVH, HD and HDF. I'm not going to share in detail on how we choose each type. I'm going to go very brief and to explain how we choose. We choose intermittent dialysis, which means it is either hemodialysis or HDF. So it depends on what you want to achieve. You want to diffusion, then you do HD. You want the diffusion by convection, then you do HDF. Well, if we decide CRRT is the better one, then again, whether you want to do CVVH, HD, or HDF, it depends on what we want to achieve. Conventionally, if we want diffusion and convection, then we do CVV, HDF. If we decide we want to do hybrid treatment, which is prolonged intermittent renal replacement therapy, then you want to do diffusion, we have SLAC. If you want to diffusion but convection, then we have SLAC-F. which is getting more popular nowadays. But the problem with SLAC, when we talk on SLAC, your SLAC and my SLAC and her SLAC will be different. Conventionally, we define SLAC as when the dialysis flow of less than 500 as SLAC. But everyone has different opinion and definition of SLAC. Some people run SLAC with a QB of 100. Some people run a QB of 300. And the dialysis flow as well. As long as less than 500, some people run 400. Some people run 300, 200, 200. And when we talk on SLAC, there's no clear timing as well. Some people run 4 hours, 6 hours, 8 hours, 10 hours, or 12 hours. So because of all this, so that's very difficult to compare the SLAC and CRRT. How we choose? I choose them based on these 4 criteria. Number 1 is hemodynamic. Number 2, what solute clearance that I want to remove. Number 3, the fluid overload, the fluid status. And number 4 is the what renal recovery do I expect. Hemodynamic. We know when we put them on SLAC or CVVHD, so there's always a risk of a drop in BP if we choose SLAC. According to this trial, the percentage of drop of BP will be, or SLAC will be 20% extra compared to CRRT. And how about solute clearance? SLAC and CRRT same. According to this trial, when they compare SLAC-F and CRRT, we notice that there will be no threatening intradialytic hypotension or the need of increased inotrope in SLAC as well compared to CVVH. Because SLAC-F, there is a replacement fluid go in. However, still operational-wise, SLAC-F is less effective than CRRT for removal of larger solute as compared to small solute. Fluid balance is another important point in AKI. We know if a patient is in the fluid overload state, then the mortality will be higher. However, if you want to ultrafiltrate the fluid more in a very short period of time, when the plasma refill rate is slower than that, then you would cause complication. The patient BP might drop, and it might cause fatal complication. So in this type of case, the patient is very overload, CRRT maybe is a preferred mode because it continuous hourly ultrafiltrate it. So there's one trial called Outcome MERA trial, which is very famous nowadays. It compares SLAC and CRRT in ICU AKI. So basically, it stated clearly there's no difference in composite outcome of 30-day mortalities and dialysis dependent between these 2 modes. However, there are a few summary. If patient is a fluid overload patient at the initiation of RRT, then CRRT would have lower mortality and better recovery of renal function. But if you put patient without shock into CRRT, then actually you increase the mortality. We know because there's some of the hospital with NSSTs, they don't have access to hemodialysis or SLAC. So sometimes they are not, do not want to refer to the nephrology. Then for those without shock, they also run on CRRT. This group of patients, they might increase the mortality risk. Of course, when we always say CRRT is better than SLAC in AKI, there are also other trials. We say the opposite, but as example on this rescue trial, when they compare the SLAC and CRRT, so you look at the red color one, the 90 days all-cause mortality, CRRT in fact is higher compared to SLAC. But the issue is in this trial, they have very comparable hemodynamic profile between these 2. And of course, they wrote there SLAC will be even better in terms of the decrease in body temperature, in terms of cost and timing, and SLAC have better solute clearance. The issue for this trial is this is a single test, and this is what I said earlier. Your SLAC, my SLAC, and her SLAC will be different. So their SLAC is 12 hours to 14 hours, whereas the CVVH is 15 hours. That's why their result is comparable. So at the end of the day, when we decide mode of the dialysis, the most important is we have to decide is whether the patient would need prolonged dialysis. If they need prolonged dialysis, then it would be better to put them on CRRT. And of course, we look at the economic implication in AKI. If you put them on hemodialysis, there's always a lower rate of recovery of renal function after they discharge the patient compared to CRRT. These are all the trials that demonstrate that CRRT is would have a better and faster renal recovery compared to HD. And when we talk on dialysis support in AKI and in ICU, sometimes there are other indications. Example, you want to support for neurology, liver, lung, cardiac, or gut. Some we do dialysis for disease modification. For septic AKI, sometimes we do immunomodulation, and some you want to remove poisoning or you want to allow the adequate nutrition and gut recovery. So I will spend some time to talk on this immunomodulation, extracorporeal blood purification. So in septic AKI, when there's a septic tissue, there will be a lot of cytokine and chemokine released in the bloodstream. All of these would potentially bring adverse outcome to a patient, hypotension. And if you perform extracorporeal blood purification, you potentially remove all the cytokine and help the patient. This is some of the example that I did. For the picture number 1, you could see we run the patient on CRT, and you could see there's a 2 dialyzer there. So basically, we put another hemoperfusion filter to remove the cytokine. And you see my staff is wearing full PPE. You know this is a COVID case. And picture number 2, I want to demonstrate to you. We know that Osiris has absorption capacity for cytokine, but sometimes we know the cytokine storm is very bad, and we want to extra removal of the cytokine, then you might need an extra filter. Or now picture number 3 is just if the cytokine is not very bad, then you just put that Osiris itself, it would be enough. Cytokine removal, hemoperfusion can be done in hemodialysis as well, as I show in picture number 1. And it can be done in SLAC machine as well, in picture number 2. Or sometimes we can actually do hemoperfusion alone without dialysis. It is also possible. This is how we do the extracorporeal blood purification in septic AKI. If you want to do diffusion, then there's a filter called amic filter, which you can put that on. But you want to do adsorption, then if you want to do non-selective adsorption, we have AN69 membrane, which is our M100 in the Prismaflex. And if you want to do highly selective adsorption, then we have Osiris, I showed you earlier. And you want to remove a lot of cytokine, then you do hemoperfusion. As I showed you earlier, some of us will do plasmapheresis as well. I used to do plasmapheresis to remove the cytokine, but it's very costly and time-consuming and complicated and complex. So nowadays, I wouldn't do plasmapheresis for cytokine removal. What is my suggestion on mode of renal replacement therapy? I would suggest if the patient is hemodynamic instability, then CRT may be the preferred choice. If patient with severe lactic acidosis, you want to stabilize the acidosis, then CRT maybe is a preferred choice. And of course, those with cerebral edema, then CRT may be better. Or those with very low potassium or low sodium or very high sodium, then CRT may be a preferred choice. Or other unconventional treatment like acute liver failure, CRT may be better to prevent cerebral edema. Of course, in CCS, sometimes you want to remove the fluid and their BP is low, you cannot remove too much, then you might want to perform scarf on them. I would like to share also, when we decide mode of dialysis, it is always complementary therapy, which means at this point, we do choose CRT, we can change to SLAC and HD when the patient condition better and vice versa. It is totally depend on the hemodynamic stability, the stability or intracranial pressure, the fluid that we want to remove, and how is the acid base and metabolic that we want to do. If you choose the mode of dialysis, it does affect the outcome. If you choose CRT as a first choice in very bad AKI, their recovery will be higher compared to hemodialysis. This would be, I think, my last second slide. I would like to share something on time-limited trial of dialysis in AKI as well. When the patient was referred to us for AKI, and when the prognosis is unclear, we are not sure whether it would improve or not, then we actually can put them on dialysis, but it should be a time-limited trial. So when we put them on dialysis, we put them on CRT, and then you observe whether they improve. If they are not improved, then maybe it's a time for us to discuss with the other team members, anesthetist team, and the patient, family to stop the dialysis service. It is very better than we keep running the CRT. Some people we use keep changing the CRT filter, 5 filter, 10 filter, etc. So I think if there's no improvement in when we do CRT, then we should have to stop them. Ladies and gentlemen, this will be my last slide. I would like to conclude my presentation today. Burden of AKI is significant in all the critical ill patients. AKI is a multi-organ effect where the organ crosstalk, as I showed earlier. AKI brings short and long-term outcome, include CV event. AKI will always increase risk of CKD and end stage. The initial AKI dialysis modality does influence the renal recovery and dialysis dependent after the AKI. And we know AKI is a serious and it is very cost consuming. Decision how to treat AKI is always complicated, and always remember AKI is never okay. With this, I would like to end my presentation.
Thank you, Dr. Tan.
Right. Is there any role of protein and salt restriction in patient with AKI or acute on CKD?
In AKI, actually, we need to increase the protein rather than resort restriction, because during AKI cycle, there will be better wound healing, etc. Usually, we want higher protein rather than restrict the
I think you're talking about possibly different scenario. One AKI that one in ICU, then of course the nutrition is part of the and so. What about the one AKI in general medical medical setting that possibly not as critically ill as in ICU? I think probably that's possibly one of the one question meant to be. So.
I think I wouldn't restrict any
right.
in AKI setting. Maybe we are not going for high protein. Also, we would know for that's a standard protein.
Yeah. Right. Since there's no more question here or waiting for further question, possibly Tan, I'll ask you one question. Usually in the past, we've been taught that AKI is usually benign, that usually AKI will recover. As times goes on, nowadays we see that they are not really benign, portion of them becoming CKD. Looking at your slide just now, can we predict which group of patients that potentially will develop CKD after episodes of AKI?
I did went through some article before, but I'm not very sure whether we can have any particular guidelines on how to predict the recovery.
Okay, you say that best is to follow up this patient because portion of them will develop CKD. But yeah.
All of them must should have a follow up.
Especially those patients who spend a lot of time in ICU prolonged dialysis, because he already has other comorbidities, already on pre-existing CKD perhaps. Yeah.
Yes.
Yeah. Where should this patient should be followed up, preferably in a primary care or nephrology?
I think in the government setting, I think primary care should be okay lah. Patient is too many.
do any. Okay. Let's
Unless
see.
there's those are
Yeah.
severe AKI, severe AKI.
Yeah. All right. There's one question here. How long can we wait for somebody who had AKI and metabolic acidosis before we propose some form of renal replacement therapy?
Again, as I shown earlier, it
Yeah.
depends on trajectory of the AKI. So you have to see the whole picture,
Oh.
and you predict, whether this AKI is going to get worse. Is as I showed you earlier in the trajectory graph, whether it's a group A or group B or C. If you think they are in the group A, I mean they are going to get worse and worse, then you have to intervene earlier. But if you think that at some point they might improve, then you might wait for a short while to observe. So it is very dependent on the case scenario.
Yeah. Okay. Usually sometimes it's a gray area, how long do we wait? There's always a question there. Yeah. Yeah, depending on the scenario lah. But in the real practice, sometimes it's difficult. Sometimes we think that the patient possibly will improve the next day. So
Yeah.
is there any other ways, markers to sort of help us? Because what we have in general practice, usually the usual things that we look at the trending of the renal function,
Yeah.
the urine output, the overall clinical pictures of patient.
Yeah.
Mm.
And sometimes, as I showed just now, sometimes we will do this full stomach stress test, to know the
Yeah.
prognosticate it, whether it will get worse or it will improve in the next few days.
Yeah. So, okay, let's see now. Any other question that we have here? All right. Okay. Similarly, it's difficult to initiate. What about when is to stop? When to stop dialysis?
Again, when to stop dialysis,
Uh-uh.
I did include in my slide, when talk on dialysis, again, there are a lot of trial on when to stop dialysis in AKI. But in general, if you see the patient condition improve, the unnatural get to wean off, and the solute clearance is the demand is already less, then potentially you might can start to behold and observe things like this.
Yeah. Okay, there are two questions here. One is bodybuilders often have a high risk creatinine and take a large amount of protein supplements. Okay, most have renal imaging and other lab indices fairly normal. PGFR often reported as mild AKI. What would be your approach to test on the actual kidney function of these young patients? This bodybuilder taking a large protein supplement, then develop mild AKI is usually reported in the lab result.
Oh, I think what the question is, when they do a routine screening,
Yep.
GFR is always mild abnormal.
Yeah. Based on the GFR.
Yeah, so they are not very sure whether this is a mild CKD or not. In this group of patients, we had to follow up them, and also check the urine FVME, make sure there's nothing sinister. If the kidney function is getting worse, then we have to ask them to stop the high protein intake.
Yeah, because okay. Next question. What will be your opinion on? What would be your opinion on sodium bicarb used as a bridging before some renal replacement therapy, and how long can we allow that? Yeah, this is the usual thing that we do.
Yeah. As I told earlier, it depends on the trajectory of AKI. If you think we can wait as a group B and C, then you want to wait for some time to see whether they improve or not. So you have to do some medical treatment. So the medical treatment I share is either the diuretics, hyperkalemia medical management, and by sodium bicarb.
Yeah. I think we need to see overall picture of the patient, not only looking at one single dose and then correct that single parameter. Okay. Right. Oh, there's other question here. Is there any Is there any roles of dialysis in patient with high lactate? Sorry, Tan, sekejap. Is there any roles of dialysis in patient with high lactate acidosis, high BP? Or I think, is there any role of dialysis? Right. Yeah, we usually come across this kind of referral, Tan. The creatinine, renal function normal, but then you referred because of the severe lactate acidosis, high blood pressure. So is there any role of dialysis in this group of patient?
Yeah, I also receive a lot of this type of referral from our ICU. When patient have lactate acidosis, we always need to, I think the best is we don't say yes or no. We have to look for the underlying etiology. We need to think, look at the patient overall and what we think is underlying etiology, and we from there. The dialysis is mainly a supportive treatment. So whether to put them on CRT, basically supportive treatment. Whether I buy time, to investigate further. That's how we do. CRT itself cannot treat lactate acidosis, but we can buy some time for further investigation. So what we do, usually I always tell my NS colleague, we need to look for the underlying etiology. Sometimes all the patients, if they are on high inotrope, 3 to 4 inotrope, their BP is very low, they will have very severe lactate acidosis due to poor tissue perfusion. In this group of patients, there is no role for CRT because the patient is going to die soon. But on the other hand, if the inotrope is not very high, but lactate acidosis is still very bad, sometimes it can be other things. So we encountered before, like a patient is due to metformin, etc.
Yes.
So you have to see what is the etiology.
Yeah, right. Okay. There's this question here about urinary cystatin. Okay. Urine cystatin, I think, as a detection for AKI.
This will be
urinary cystatin.
this will
you
be
use that?
No, I never used before. No, don't have any experience at all.
Yeah.
Biomarker, AKI biomarker.
Yeah, AKI biomarker. This Engels is a urinary and plasma Engels has been for many years. Again, there's been many years of these biomarkers, but what their actual can they contribute to our management of AKI?
We are actually waiting for the best biomarker, which when any patient will come, you just do, and then you will tell you, or this one going to need dialysis, or this one will not, but there's no such biomarker. So there are a lot of debate, etc. So I myself also do not have much experience on biomarker.
So regarding this biomarker, there's just a question pop up here. Can AKI requiring regular hemodialysis? Then how long? And any biomarker available, we know that prognosis patient progress. All right. Okay, the question basically is asking any biomarkers that are available to predict the prognosis of patient progressing to end stage.
That I'm aware of.
Yeah. As far as I know now. Yep.
Yeah.
Oh, the other question is, can acute kidney injury progress to regular hemodialysis? I guess you have answered that in your slide, right? A portion of them will progress to CKD and eventually to end stage. I think following that question, any predictive parameters that predict that this patient will likely go into end stage?
I think also it would depends on how bad is the AKI, and whether they are hypotensive for very long, they have a lot of ATN, etc. And to know whether and how fast their recovery. If their recovery is very slow, then the chance of going to the end stage would be very high.
Okay, Tan. Right. Well, there are no more further questions from here. Okay, since there are no further questions, Tan, I think we agree that we have quite a very fruitful discussion this afternoon. Thank you very much, and hopefully that we have a nice weekend to all of you, and give back to the host, Dr. Priscilla.
Thank you, Dr. Zaiha and Dr. Tan, for the fruitful session. I think there's one last question from Dr. Rahul
Cannot see here. One the last question.
from the chat box.
All right. Okay.
He was asking if patient upper GI bleed urea 35 creatinine 2.
Oh, okay. All right. Okay. There's another one here. Sorry, Tan. This is another common scenario, when you get urea very high due to upper GIT bleeding. In that, you see the renal function is not that tremendously high that usually that you dialyze the patient, but then they refer to you because of the high blood urea before they're going to scope the patient. So how do you approach that, Tan? This is another common scenario.
I used to receive this referral as well, but usually we will just tell our surgical colleague what their worry is. It might cause a worsening bleeding, So it's not they insist, and they are just worried of bleeding, worsening bleeding. And from our point is, the urea is high is because of UGIB. Let's say overall, if the urine output is good, other parameter is okay, you think this is due to upper GI bleed, then there is no role for dialysis at all. On the other hand,
right. Do you aware any cutoff level of urea that force them not to scope?
No. Actually, a lot of time this are referral. The surgeon is very receptive, They go in. Of course, we always tell them post scope if you need any support, we could support you. That's the thing they want. They are after scope, they're bleeding, and then there's no support, things like this.
Yeah. Similarly, the usual controversial level of urea before going to procedure or op. This is usually by our anesthetically to dialyze first before going to the operation. Usually our surgical colleague will caught in the middle.
I think there's actually no guideline on that.
Yeah.
It also depends on our discussion with the team and the give and takes.
All right. Okay. All right, Priscilla, I think that will be the last one, no? The one that I can see from here.
One more question. Is
Where
there
is it?
any role of sodium bicarb in case of lactic acidosis?
I think Dr. Tan has answered that. Just now. Yeah.
Okay.
Meaning that you need to see the whole scenario of the case, see the underlying causes. Am I right, Dr. Tan?
Yes, there's no right or wrong whether you can give or not give. See the scenario,
Yeah. Okay. Is there any more?
I think that's it.
All right. Thanks again, Nathan. Thank you very much for your very comprehensive and clear, lucid, concise talk on AKI. Right. And then
thank you.
All right.
Thank you, team.
Okay, Priscilla, thank you very much.
Okay,
nice weekend, all of you.
Okay, thank you, Dr. Zaiha and Dr. Tan, for this fruitful session. We will see next week for another webinar, which is Dermatology Month. Thank you.
All right. Okay. Bye-bye.